Derek, I think you can tell our speakers that the YouTube link is live. So if they want to send the link to anyone.
I'm just getting that up and I'll put it in the chat box.
I'm not getting on the phone. Professor Ellis is pediatric intensive care at the Hong Kong Chinese University. But we are to have a pediatric program, so maybe that could be. So we will.
Just for the information of everyone, I have put a YouTube live link in the chat box. So you can copy that down and forward it to any of your friends or colleagues. So even if they would like to join, they can do that without logging into the Zoom itself.
Derek, one thing, when we start, you have to put the link again because those who haven't entered
I'll do that.
won't be able to see.
I'll do that. This was just for our panelists.
Okay.
Dr. Russell, you admitted everyone?
No, I didn't say. I think you must have. You had.
No, I'll request all our other guests. We made you co-hosts for convenience of speaking. Please don't admit anyone.
So we haven't got. All right, we might start. Shall we start?
We have yet to admit a few, Dr. Russell.
No, all I admitted. All I admitted right now.
The others will join.
All are in? All right.
There's a couple of minutes more, so they'll probably join. We're just waiting for Ellis, but he'll probably join us later. All right. A very good morning, good afternoon, good evening, and good night to those of us from Australia. Now, Derek, is Cahill here?
No, I don't see him as yet.
Okay. Welcome to the 48th of our series of international panel discussion webinar conferences of the Department of Education of the International Chair, the UNESCO Chair in Bioethics, which was University of Haifa. Now, as all of you would know, this has been going on we've been covering a number of areas, and this happens to be the 48th, where we have a very distinguished panel, international panel, who are going to take us through the theme that today is about ethical and clinical challenges for critical care and intensive care in the COVID pandemic. Now, the important aspect of all this has been over the last almost 18 months has been bringing out, focusing on bringing colleagues from around the world, or in fact, we have most of the regions covered all the time, and bringing solidarity and cooperation, an Article 13 of the Universal Declaration on Bioethics and Human Rights. So this has contributed to that important principle. And we've had various, as you know, disciplines come in here. So today we have another very important discipline and important aspect of the pandemic that we are facing. So before I could go any further, let me ask Professor Mary Matthew, the co-chair and the head of the program in India, to welcome you. And
thank you, Dr. Russell, and good day to all. This is our 48th webinar, and we've been having these series ever since the COVID pandemic had started. So from last year onwards, we've been continuing these series, and it has helped us to know what is happening around the world and to tell everyone that we are all facing the same problems together and that we are not alone, and somehow give each other a sense of hope that we can all continue and do the best that we are doing. So today's webinar is actually a continuation of the series that we started on ethical issues faced by anesthesiologists and intensivists. So these are the ethical challenges. And if those of you who would have been there last week, it was really a very nice session, not last week, 2 weeks ago. A very nice session and really an eye-opener for all of us. I am a pathologist by profession, and there are a lot of things that I really do not know what is happening on the hospital front. And the webinar 2 weeks ago was really, it opened my eyes to the difficulties faced by a lot of people who are working within the hospital and trying to protect patients, protect their families, and protect themselves. So today we have a panel that is going to tell you more about this. They're all distinguished in their own way in their fields. And I would encourage all of you to please put your questions in the chat box. Today I will not be moderating, and Dr. Derek is here to moderate. And but we do want to tell you that there is a YouTube live link that has been put in the chat box. If you wish to share, please feel free to share it to your colleagues and friends who want to attend this webinars. And we encourage also the speakers because most of the time we run out of time when we are doing these kind of webinars. So if you would like to answer the questions directly in the chat box, please feel free to do so. And if you do have material as in literature or any other anything else that you'd like to share, please put in the chat box. We do have a lot of students also who come and attend these webinars. So it's also, in addition to sharing information, it is teaching and learning for our medical students. So I thank all of the panelists here today, and with that, I will hand it over to Dr. Derek. Dr. Derek.
Thank you,
Dr. Derek,
Professor Mehdi. We'd just like to welcome Dr. Ellis Horn, who has joined us in the meantime. He will also be one of our distinguished panelists. Welcome to you, sir. and also Professor Des Cahill from RMIT University in Melbourne, Australia. Welcome to you, sir. Good to see you as always. Dr. Mary has given you most of the house rules, and for all the participants, especially those who have just come in, you may feel free to post your comments or your questions into the chat box, and our experts, even if we cannot take them live, they will be answered to you in the chat box as well. So when our speakers are not speaking directly or presenting, can I request you to address the chat box? Each one of you is a co-host, so you can address that. You may go to the chat box and share any documents or answer the questions that are there, especially if they are pertaining to your part of the world. So with that, I hand you back to Dr. Russell to take us forward.
Thank you, Derek. I want to acknowledge, where is that, Dr. Lincoln.
Dr. Ellis, Dr. Lincoln, yes.
Dr. Lincoln, oh yes, Dr. Lincoln. Sorry, I was looking for you, Lincoln Pereira. He's one of the committee from the Latin American region and the Caribbean, who contributes an important part. The president from there. Also Des Cahill, Professor Des Cahill from RMIT Melbourne, who writes the executive summary. I wanted also to acknowledge Leon Ogetu from Kenya, who's also part of this program. So welcome, Dr. Ellis, Professor Ellis, welcome to you today to this program. And again, Alvin is another important part. I want to acknowledge Alvin Chan, Dr. Alvin Chan's role on this committee and the contributions from the different regions to the International Department of Education of the UNESCO Chair in Bioethics. Now, we have three, as we have done and do now, we're starting with the three very interesting presentations that will take us, set the scene, as it were, for us to then move on to the panel discussion. So we're going to start with Dr. Mukul Kapoor, who is going to do the first presentation, which is going to be on critical care issues during the pandemic in patients undergoing specialized surgeries. And Dr. Mukul Kapoor is, of course, a graduate from the AFMC, the Armed Forces Medical Corps in Pune, and is specialized in cardiac anesthesia from AIIMS and works as the cardio anesthesiologist in the Army Medical Corps for many years. He's also the former editor of the Journal of Anesthesiology and the Clinical Pharmacology, and a former president of the Indian Association of Cardiothoracic Anesthesiologists. And he is currently, of course, the head of, at the, I think it's the Max Smart Hospital, the director of anesthesiology there in New Delhi. So, Dr. Mukul Kapoor, I welcome you and hand it over to you for your presentation. Thank you very much for your contribution today.
Thank you, Russell. I'll share my screen. It's a pleasure to be, speak in front of such an august audience. And I don't know whether I'll be doing justice to whatever was required from me or not, because I've tried to, focus not on studies, but on practical issues which I faced or my hospital faced during the pandemic. So to take you through the journey, what was the primary problem? The primary problem with the COVID-19 pandemic was undoubtedly the impact on healthcare, the diverting of resources, and overall crisis for hospital beds. We had to postpone all types of surgeries or not do them at all because we wanted to minimize whatever we could to care for the healthcare, minimize the exposure to the patients and to the healthcare workers. Surgical disciplines require very large amount of ICU beds, especially specialized surgeries like cardiac surgery, transplant surgery, onco surgery. And this problem caused a lot of cancellation of elective surgeries. We had to relocate all our staff from the specialized units to emergency departments and ICUs. And of course, like everywhere in the world, critical supplies were rationed. We had problems of getting ventilators, PPE, blood products, everything under the sun, which was considered critical, was a problem. As a result, many patients deserving ICU care could not get ICU care. The only people who got ICU care were patients who were very, very sick. We had to curtail all our surgical lists, and we definitely deprived a lot of patients of good ICU care. Many patients who were scheduled for surgery, for specialized surgery like heart surgery, transplant surgery, had to go down the waiting list. And we followed a triage with only the sickest of them all getting a chance to get operated. Even the cases which were scheduled for surgery, we could not assure them a bed. We had to cancel a lot of surgeries at the last moment because suddenly in the morning we were told that lots of cases have come in the night who required ventilation for COVID, and our ventilators have got diverted to the other ICUs, the COVID ICUs. Apart from that, we had a crisis of staff. A large number of the specialized ICU staff had to be diverted to the COVID ICUs because there was a shortage there. And it was not only diversion. The problem was when they finished their rotation in their roster in the COVID ICUs, they had to be quarantined thereafter. So they were neither available to the COVID ICU nor were they available to us. To compound the problems further, we had a lot of patients who underwent cardiac surgery and transplant surgery who developed COVID after the surgery. It is possible that they developed it because they were in the window period when they were taken up for surgery. And once they developed COVID positive in their RT-PCR, it was not easy to find a bed to shift them to the COVID ICU. It was very difficult because COVID ICUs were always overflowing, and trying to shift a patient from a non-COVID specialized ICU to the COVID ICU was a difficult task. So many times we used to have mixing of COVID and non-COVID patients in our ICU. Another thing I would like to point out is most of our specialized ICUs do not have negative pressure isolation chambers, and the chance of spread was real. As a result, a lot of our staff turned positive while treating supposedly non-COVID patients. The staff in the COVID ICUs also face the problem of a dual nature of managing the protocols for COVID as well as managing the protocols for the specialized surgery. All these specialized surgery like the lung transplant, the liver transplant, and cardiac transplants have the special needs. And managing all that with the COVID protocols wasn't easy. Then a lot of patients, especially the ones who undergo transplantation, are on immunosuppressive therapy. Now these patients, because of the presence of COVID in the atmosphere, we needed special care to manage them. Discharge from the ICU to the wards also wasn't easy. We were scared of two things. One, if you send them to a normal ward, they might get positive there. They're already immunosuppressed. And as it is, even sending them to a non-COVID ward wasn't easy because beds on either side were difficult to get. We had to tweak the immunosuppressive therapy. In addition to that, later on, in the pandemic, what we faced was secondary infections. So we had to protect these patients from secondary infections like mucormycosis. And this threat of secondary infection was real and very scary. As far as hemodynamic support was concerned, a large number of our COVID patients needed ECMO support. We didn't have adequate number of ECMO machines available in the hospital. Apart from this, whenever a patient was put on ECMO support, the cardiac surgery specialized technicians and perfusionists had to move to the COVID ICUs to manage the ECMO. So again, that depleted our staff further. Our hospital tried to buy ECMO machines. However, since the demand for ECMO machines were very high there, at that time, it took a lot of time to procure new ones. Coming to the next problem of lung transplantation. A number of patients who developed COVID developed destroyed lungs. And once they developed destroyed lungs, they became ventilator dependent. I remember my friend Arun Mehra also phoning me up twice for a colleague of his who had gone to the stage. And he wanted my help as far as lung transplant was concerned. But the problem was that there were limited centers with expertise to perform lung transplant for the first thing. And the second thing was that lungs weren't available. Lungs were not available because most of the lungs which come for transplantation come from accident victims. Because of lockdown, hardly any accidents were there, so we weren't getting enough lungs. Plus, in case you needed to transfer this patient to a center which had the expertise to do lung transplant, you needed an air ambulance services. The air ambulance service was overwhelmed with work. In addition to that, they became very, very expensive to manage. It was economically and socially very difficult for the next of kin to meet the requirement of lung transplantation. We also had problems of altered coagulation during this period, which was a feature of COVID disease, of course. As a result, the neuro ICUs had an additional load of ventilator-dependent patients post cerebral thrombosis and hemiplegia. The cardiac ICUs had an additional load of patients after MI and patients who had to undergo pulmonary embolectomy because of pulmonary thrombosis. It was very difficult to manage the hemodynamics and oxygen saturations in all these patients. As far as Onco Surgery was concerned, every day in the morning, we had to check for and confirm a bed availability in the ICU before we could wheel a patient into the operation room so that they could undergo surgery. A lot of our scheduled cases got cancelled and they went down the waiting list. And possibly when they got operated later, they were sicker than what they would have been at the time in case the surgery had been done earlier. Most of them could only reach the operating room only if they crossed the triage barrier. And then came the curse of the mucor. Many of our critically ill patients developed mucormycosis. And this mucormycosis was mainly affecting the paranasal sinuses, and in lots of cases, it had migrated to the eyeball. In some cases, it was also affecting the lung. The availability of amphotericin B and proconazole was very limited. The country could never have catered for that, the number of cases which we had during that period. I don't blame anybody for it. We never thought we would need so much of mucor, amphotericin B from mucor. As a result, patients were undertreated as far as antifungals were concerned, and many of them had to undergo debridement of their nasal sinuses. And I personally got many exentrations of the eyeball done. Many also died despite treatment with antifungals. There were psychosocial issues as far as the staff was concerned because the atmosphere was very sullen. There were lots of our staff members whose family members were suffering from COVID and they needed care also, but they had to work in the ICUs and they couldn't be left. The mortality rate was very high, and this also affected the behavior of these staff. Plus, working for long hours with PPE without being able to take food, fluids, had a major impact on the morale, and it led to depression in many of them. One, I don't want to say it, but I think everybody should know, one young doctor of my hospital committed suicide because he could not see so much of mortality. It was unfortunate, And I still remember that scene. It was very, very unfortunate. Somebody committing suicide because he went into depression. Unfortunately, he never expressed it to all of us. Otherwise, maybe we would have helped. Apart from this, BP also reduced the efficiency of the caregivers who need a lot of dexterity and skills to manage specialized ICU, especially arterial lines, central venous lines, and IV alimentation, etc. Access to care was limited because everybody had to get an RT-PCR done before ICU admission. So patients with cardiac failure, renal compromise, neurological compromise, liver failure, you name the problem, they needed to wait in the triage areas and emergency rooms for definitive therapy to start because the RT-PCR results had not come out. We could not decide whether to send them to the COVID ICU or the non-COVID ICU, and they were left in the triage for a long period of time. So as a result, treatment was compromised. Primary angioplasty and thrombolytic therapy is supposed to be done in the golden hour. Again, that did not happen. We denied people the golden hour benefits of these primary therapies. Even tracheal intubations used to get delayed because of two things. Either a ventilator was not available to place them on ventilator, or the healthcare workers was hesitant to put the patient on the ventilator. A lot of my staff felt that, sir, if you put them on ventilator, they're going to die. Let them be without ventilators. Rather try it out. Rather try to put them on BiPAP, etc. And even performing CPR, I know for sure that lots of people did not perform CPR in patients who had COVID. Then came the scare of the oxygen shortage, which was well published in media across the world, the scare of oxygen shortage in India. The demand for oxygen could not be met with the supply of oxygen. We had to cancel specialized surgery during this oxygen crisis period. Many cases needing emergent and urgent surgery also need to be deferred, and possibly that led to higher mortalities because they were operated later on. Patients on ventilator during this period of oxygen shortage always had the sword hanging over their head. I know of some hospitals which even told patients on ventilators, and they told the NOQ that your patient is on ventilator, we are not sure whether we can give adequate amount of oxygen to them later on. Please take them away to a place where oxygen is freely available. Patients also came for surgery post-COVID because of complications. And these patients were in a very sick conditions and generally in very poor conditions. They all had multi-drug resistance and very poor respiratory function. Plus they had problem of thromboembolism and complications of COVID, which needed special attention. Post-COVID CABG surgery patients had a very difficult ICU course. Thank you very much.
Dr. Russell, you're muted.
Oh, sorry.
Yeah.
Thank you, Dr. Mukul Kapoor. It was very interesting to learn about how you dealt with it in Delhi. We were all watching from outside here and what was going on there. So thank you very much. We'll come back to you in the panel. Now, our next, we have got three very distinguished speakers. I said I should have actually introduced all three of you. One, of course, was Dr. Mukul Kapoor, who you just heard from India. The other next speaker is Dr. Leonardo Carvalho, who is the scientific director for the Society of Intensive Care Medicine at Minas Gerais in Brazil. And so Dr. Leonardo Carvalho is going to, will be speaking. Before I present the topic, I'll also introduce to you a very distinguished, another distinguished panelist from United Kingdom. And this is Dr. Danish Siddiqui, who of course is a consultant in anesthesia at the University Hospital of the North Midlands at the NHS Trust in United Kingdom. I'll come back, he will be speaking after Dr. Leonardo, and I will introduce the title. So Dr. Leonardo is going to tell us, speak, and his talk is going to be COVID-19 pandemic and the intensive care challenges that they faced in Brazil. Being the scientific director for the Society of Intensive Care Medicine. Over to you, Dr. Leonardo Carvalho.
Thank you, Dr. Rosso, and thanks to Dr. Linko for the invitation. My name is Leandro Carvalho. I'm an intensive care physician and anesthesiologist in Brazil, and I've been working for 1.5 years, mainly with COVID-19 patients in intensive care and emergency units here in Brazil. And I'm also training healthcare professionals with simulations together with our Regional Society of Intensive Care. There is so many. I will start to share my screen. This is the logo of our Regional Society of Intensive Care. As Dr. Rosso said, I'm the scientific director of our society and also the coordinator of some courses along with the Society of Critical Care Medicine, the American Society of Critical Care Medicine. And I'll start talking about the next few minutes about the clinical and ethical challenges we're facing in dealing with the serious cases of COVID-19. I will start by situating our reality in the last months and what we expect ahead. And here's my city, the city of Belo Horizonte, that is next to São Paulo and Rio de Janeiro, 400 kilometers from Rio de Janeiro, 500 kilometers from São Paulo. And in Brazil, we had 21 million cases confirmed of COVID-19, almost 590,000 deaths with a mortality rate of 2.8%. As you can see here, we have some peaks of some spikes in COVID-19 cases, the worst from mid-March to the end of April 2021. And you may have already heard about Manaus case. There is in the heart of Amazon forest. It is a not very populated area, although Manaus is a city of 1 million inhabitants, but it was marked by a catastrophe of ill-planned healthcare policies, lack of oxygen and intensive care beds, and the spread of a new variant, the P1, which subsequently harmed the entire country. Well, but fortunately, with vaccines administered since the beginning of the year, we have partially reduced the new cases and deaths. And we have now 34,000 cases per day. The record high was 1,015 or 115,000. And we have around 650 new deaths per day with a record break of more than 4,000 deaths per day. And despite the political turmoil and some misgivings and delays, the population's hesitation with the vaccine is not very strong. About 68% of the adult population are on a dose and 36% fully vaccinated. The Delta variant is not prevalent, but we expect it to be in the coming weeks. And Rio de Janeiro is the epicenter of the Delta variant spread. And they are having lack of intensive care beds and in a peak nowadays. Well, in the peak of the pandemic in mid-March, there was a lack of ICU beds in all Brazilian states. And our reality was that emergency rooms clinical wards, and also operating rooms were hastily transformed into critical care beds to receive patients with severe cases of COVID-19, most of them intubated and on mechanical ventilations. Fortunately, many patients were left out of ICU beds or even with no assistance at all.
Me? When?
In several places, oxygen was lacking, sedatives and other medications were lacking, and especially professionals of training of intensive care were lacking in all states. This map shows that in mid-March, many of the Brazilian states have more than 90% of ICU beds occupied. The richest and most populated states still had a slightly better situation, but they also had almost 100% occupancy the following months. ICU beds in Brazil can be divided into public beds in blue and available for the entire population, and private beds in orange that are available to those with private health plans, corresponding to 23% of the population. Beds are also poorly distributed by state or region, and some places have less than one bed per 10,000 population, others between 5 to 10 beds per 10,000 populations. And as you can see here, in total, we increased from 44,000 to 68,000 ICU beds, but they were insufficient at the time of crisis. Here is a work published by a fellow intensivist, Dr. Jorge Salu from Rio de Janeiro. He talks about the challenges of intensive care in the COVID-19 pandemic in underdeveloped countries. And his arguments, I totally agree. We needed to increase the capacity of ICU, implement systemic triage to define who needed the ICU and whether the bed was available, and reduce the difference in availability of public and private beds. Also, we needed to train non-ICU personnel to work with critical care patients, increase multidisciplinary team, and deal with ICU patients in out of ICU environments. We had some COVID-19 specific challenges, like increased staff demands. We needed more ICU beds, sicker patients, and we have burnout and sick leaves. We have to deal with PPE supply, proper isolation measurements, and assure effective infection control measurements. And concerning challenges of process of care, implementation of evidence-based protocols, and use of structured checklists. And we needed to improve communication and handover practices and improve quality of care in the wards. I hope that I have contributed to illustrate the situation experienced by ICU professionals in Brazil, and I look forward to and hope to add to the debate. Thank you.
Well, thank you very much, Dr. Leonardo, for your excellent presentation, giving us an overview of what was how we dealt with the pandemic in Brazil. Our next, and we'll have you again in the panel, Dr. Leonardo.
Okay.
Okay, so I'm going to introduce now. I've already introduced Dr. Danish Siddiqui, who's going to present us, be the next presenter. and it's the new challenges in critical care during COVID. And Dr. Siddiqui is talking to us from United Kingdom, where he's the consultant anesthetist at the University Hospital of the North Midlands, of course, the NHS Trust. So I will hand it to Dr. Danish.
Thank you very much, Professor D'Souza.
Yes. Welcome,
Can
Dr.
you see
Danish.
Thank you. Can you see my presentation?
No, we can see your
Not
screen.
yet,
I
you can
think.
just see your screen. Just go to the presentation itself.
Can you see it now?
Yeah, full screen, please. Yeah.
Lovely. Thank you very much, Professor D'Souza. And it's been a pleasure to listen to the previous speakers. There might be a little bit of an overlap, but I'll try and minimize the overlap, but present the solutions to those problems that we all had in this talk. So my name is Danish Siddiqui. I work in a town called Stoke-on-Trent, which is famous for its pottery. It's famous names like Royal Albert, Port Mairon, Wedgwood. These all come from this particular city. And I would like to break my my presentation today into three different perspectives. I'll start with patient's perspective, and then I'll move on to staff perspective and organization perspective, and then discuss them individually. So let's start with the patient's perspective. And we know that ICU admissions have always been quite a difficult and complex issue, and more so in a healthcare system like NHS, which is socialistic medicine funded by the taxpayer money. It is quite difficult when a senior taxpayer, for that one moment in his life, wanted healthcare in his advanced age, and we had to deny the ICU admission to that individual. So it was quite challenging ethically, and to really not provide an ICU bed to a sicker patient, and instead choose a patient who has more chances of surviving that ICU admission. So that was the first challenge that each intensive care consultant had. The second thing we had was that there was a differential rise in the number of cases in England. London being the first city that was hit, it was hit very bad, and it was hit very early as well, possibly because of the population dynamics, or underground tube system. We don't know what it was, but the intensive care beds were overwhelmed, and there was no capacity within a matter of days. And what was done for the measures taken at this point was to relocate these patients up north as far as to Manchester, which is about 5 hours drive from London. So all the stable patients were transported from London, and this brought its own communication challenge, because the relatives were left behind. So communicating with the relatives was the next challenge. And what we started doing in this scenario was we introduced FaceTime calls or video calls twice a day at set times. So the relatives could all huddle together at those times, see their loved ones, get an update, and ask questions about their treatment and their progress. So that was quite comforting for them to have those communications going on at least on a daily basis. The second thing that was introduced in this time was that whenever we noticed that a patient was deteriorating, we introduced a system called triangular calls. Now, these triangular calls were very innovative. We had patients' relatives on one end, the healthcare staff on the other end, and as an intermediary to bridge those complex issues, we introduced a third person. And this third person was, depending on the patient's faith, either a priest, an imam, a pandit, whatever it was, but to break down those complex problems, he would intervene and make things a lot more easier for them to comprehend. And that was quite made things quite easy for them. Now, other than this, when we had a patient who was imminently not going to make it and we were withdrawing treatment or stopping treatment to these patients, we were giving choices to the family to either see their loved ones on a FaceTime call, on a video call, or to come in and visit them personally. Video calls were made for these patients in the last moments, and staff ensured that these patients were comfortable, were well energized, and the relatives do not get distressed. And it brought some sort of a closure to the family, that they could see their loved ones pass away in a comfortable state. The patient's relatives who wanted to come in to visit them for the final time, because of lockdown, it was quite tricky. So they were sort of arrangements were made so that they could come in, visit these individuals. The problem that arose subsequently was that they had to self-isolate or quarantine themselves for the next 10 days. So they would miss out on the funeral. So all these communications were made to them, and things were taken on from there. Now, because of the high number of deaths that were happening in the hospital, especially in the intensive care unit, we arranged follow-up meetings. These meetings would typically happen a few weeks after the patient had passed away. And the idea behind these meetings was that the family could come back and discuss certain problems, certain issues, which they couldn't at the time, share their grievances, and, just to bridge that communication and prevent any subsequent litigation and things like that. So that was the initial idea behind them. But to our amazement, it was the other way around. The family came back extremely appreciative of the efforts made by the intensive care for the relatives in their final days, and it was just an eye-opener that we do not realize that the kind of changes that we make in someone's heart in their final moments, in the final moments of their relatives' lives. So it was quite an eye-opener. Moving on to the staff perspective. Now, we've always had this problem of flu pandemics and the surge in the winter admissions in ICU, and it's not anything unusual, but COVID was unprecedented. We had a sustained surge almost twice or thrice a year, and it was imminent that the staff was at their lowest in the emotional health, and they were sort of at the verge of a burnout and breakdown, and something had to be done to prevent these things from happening. So we instituted certain rotas which gave them a breather. These rotas were typically of the nature that the staff worked for 5 long days, which was enough to break someone down. At the end of those 5 days, they took 5 days off. And those 5 days, there was a complete switch off from the hospital work and COVID, and they had time to recuperate and come back for the next 5 days again. And we found that the staff found this rota quite helpful to continue their work, and staff sickness and illnesses were significantly reduced from this. The other thing we noticed was because there was a huge demand for level 3 or ICU beds, all the ICU beds that were available in the hospital, other than the adult ICU, that is the pediatric ICU beds, were made available. So all the pediatric patients who were ventilated or were transferred to a specialized children's hospital in whichever was in the vicinity. And these pediatric ICUs was where the adults were being looked after. That was a special challenge for the pediatric trained ICU nurses, I mean, they didn't have a clue about the adult doses. They had no idea about ventilator settings. And most importantly, which to our amazement, the communication between the dying patient and their relatives was the hardest one for them. As a doctor who treats primarily adults, I find it very hard to communicate with the family of a child who's dying. And it was the other way around for the pediatric team, that they, and the pediatric doctors as well, that they couldn't comprehend speaking to someone who was just like them and dying, and they were much more comfortable when it was a pediatric patient. So that had to be addressed as well, and we tried to introduce, we used to bridge that by introducing adult intensivists to help them out in that scenario. So that was to do with the staff morale and their well-being. What we also introduced in these during these times was something called as darkroom meetings. So every week we had darkroom meetings. This was based on a principle of misery begets misery. So we were all in the same boat, and only by sharing our experiences and our fear can we overcome the problem that we were going through. So there were dark rooms where it was quite anonymous. It had a very indiscreet entrance. Nobody knew who was speaking and who was sitting and communicating, but it allowed them to offload their emotional baggage and resume their work back again. And that helped them, the staff, in a big way. From the organizational perspective, this was probably the only time in my about 16 years in NHS that I've seen that almost near seamless organizational or operational management was seen. There were no sort of back and forth communication. What was decided was being executed and it was being delivered. So, for example, if a patient was coming to A&E or emergency department, there was a set trigger points that if his oxygen requirement goes up beyond a certain point, if the deterioration score beyond a certain level, the emergency department would just phone the ICU that this patient has deteriorated, needs an ITU bed. Without the ICU going back to review the patient, the ICU will create a bed and bring the patient across. So it was very smooth transition. Likewise, if a patient in ICU was getting better and needed a ward bed, the ICU would inform the respiratory ward or whichever ward was suitable that such and such patient is suitable for the ward now, despite being on respiratory adjuncts like BiPAP or CPAP. Board would never ask a question. They say, that's fine, we have a capacity. And this was quite a new thing for us to see, that the communication, the hassles were so limited. We were just, patient flow was just very smooth. The other thing that was noticed was fast tracking of the post-mortem process. So autopsies were almost never done because of infection issues. So to minimize the infection in staff, almost if it was a straightforward case, there was no autopsy needed. If the diagnosis was tricky, then post-mortem CTs or other ways of establishing the diagnosis were undertaken. And this again helped in fast tracking the post-mortem process, and bodies were handed over to the funeral services very, very early on. And yes, and finally, I think from all this, I would conclude by saying that this was probably the only time when we noticed that COVID actually brought down all the barriers that we had created for unknown reasons and for unknown number of years within the healthcare organizations. And it was an eye-opener truly for all of us. Thank you.
Dr. Russell, you're muted. Yes, yes, now.
Okay, sorry about that. Thank you, Dr. Siddiqui. Thank you very much for that excellent overview on the what the intensivists or critical care colleagues dealt with during the COVID in United Kingdom. Now, before I go to the next part, which is going to be the interesting discussion, I want to acknowledge that we have Dr. Arun Mehra. I should have actually said that in the beginning, but who has coordinated this, the last and the current number 48. He did the 47 and 48 webinar in bringing the critical care and intensivist to this webinar. So now I'm going to move on to the next portion of this program, which will be discussing from this panel. We have in this panel, we already have the three, and I'm going to introduce the other international panel members that we have today with us. We have Professor Dr. Ellis Hun, who is from Hong Kong, but he's the he's the head of the pediatric intensive care unit at the Children's Hospital of the Hong Kong Chinese University, or the Chinese University of Hong Kong. And so Dr. Ellis Hun is going to be with us, who's here. And then we also have another very distinguished panel member from Kenya, and that's Dr. Liz Kinwa, who is from the critical care senior physician and the founder of what is the founder and director of the Mentor Medics from Kenya, I think from Nairobi. And we have the next other, we have Dr. Muzaffar Khan, is of course very interesting because Dr. Muzaffar Khan is a consultant intensivist at the Princess Royal Hospital in Telford. But importantly, Dr. Muzaffar Khan was in Dubai at the United Arab Emirates, and he was contributing to the COVID program. And so he's going to be a panel member giving us the work that was being done in Dubai, which is of course of the UAE. And finally, we also have with us Dr. Ranjit Chatterjee. Dr. Ranjit Chatterjee is from India, and he's in charge of the intensive care program at the Swami Dayanandra Hospital in Delhi. So with this distinguished panel, we also have the other the presenters who, of course, once again, it's Dr. Mukul, for those who have joined now, Dr. Mukul Kapoor from Delhi, the senior anesthesiologist from the Max Smart Hospital in New Delhi. We have Dr. Danish Siddiqui from the consultant in anesthesia at the University Hospital at North Midlands in United Kingdom, and Dr. Leonardo Carvalho, who's the scientific director of the Society of Intensive Care Medicine in Minas Gerais, which is in Brazil. So I will hand it over to to Professor Colonel Derek D'Souza, who's going to compare or to moderate this important part of the panel discussion. Over to you, Professor Derek.
Thank you, Dr. Russell. And of course, before we go ahead, I think all of you have been witness to these wonderful presentations that we had from three different parts of the world. And what was so amazing about them has been that it wasn't just a presentation as such, but each of our speakers touched on very personal aspects that they had noted. It was as if they were literally dissecting the layers of the complexity that this pandemic has brought to all of us. And my hats off to all the anesthesiologists and the critical care specialists, because when we talk of healthcare professionals and workers on the front line, I think, to use an army analogy, that it's you guys who literally take the bullets. To be at the front line, to be there when it's time to say the last goodbye, to be having the one to say that there is no ventilator, to be the one fighting for oxygen at all times. So thank you all for sharing that. And I'm glad that most of it is a little bit in the past, and I hope none of us have to see those dark days again. Let's start with the first, the lady we have on the panel. So I'll address Dr. Liz first. What has been your experience, Dr. Liz, in Kenya? Has it been similar, or has something been different, something else that you all tried out in critical care during this very difficult times?
Thank you, Dr. D'Souza, for the opportunity to give my personal experience with management of COVID-19, specifically in the critical care setting. So my personal experience has been, working in Aga Khan Hospital. It is an institution that the focus is on international standards of practice and evidence-based medicine. However, we do work in a resource-limited setting. And my experience has basically been the same as everybody else, with a limit of beds, having to decide which patient needs to be admitted into the critical care unit and which patient doesn't need to be admitted. And one of the worst parts about it is talking to the relatives. When you see a patient, in our setting, we do not have ECMO, extracorporeal membrane oxygenation. So when you realize that a patient is hypoxemic and it's at a point of no return, that conversation, having that conversation with the relatives is one of the most difficult aspects of the job, considering the patient has been there for a really long time. They are constantly asking about the bill, and then here you are telling them the bad news and the bad prognosis of the patient and telling them to be ready for any eventuality. Thank you.
Thank you, Dr. Liz. Yes, these were two definite issues that we also faced, because India also, and this hit very many people, and especially those with low socioeconomic status. It became very difficult to treat them. And then you have rising bills on one hand and having to convey the bad news. And in fact, very often we found that the patient was literally abandoned at the end because nobody could pay the bill in the first wave, at least. It was almost like no one wanted anything to do with the patient anymore. And we had to literally think of disposing the body and all that. So thank you for highlighting that as well. We'll move on to Dr. Muzaffar Khan, who I think during the height of the pandemic, your experiences were in Dubai, if I'm not wrong. So what was different there for you, sir? Anything different that you all could do, and how was it overall?
Thank you very much, Dr. D'Souza, to having me here. Yeah, at the time of the first wave of the COVID, I was working in Dubai in one of the corporate hospital there called as Al Zaira Hospital. So the same issues when discussed with Dr. Siddiqui, Dr. Carvalho, and everybody, that overwhelming of the system was really a problem to start with in the first wave of the COVID pandemic. So we were not prepared. Nobody was prepared, and nobody was knowing what is going to happen. So definitely there was shortage of bed, shortage of staff. which we have started with. And yeah, so we had an ICU of 10 beds to start with, and we ultimately extended up to 30 beds because of the number of patients which we were getting. The good thing was that the administration system from the UAE was very good in the term. The DHA has this Dubai Health Authority has taken all the responsibility of managing patient transfer, which patient will go to which level of care. So that was good thing from their side. But when they have actually ordered us that we have to extend our bed capacity to 30, and this was a big problem to us because we don't have that many trained ITU physician and ITU nurses at all. So we had got some nurses from endoscopy suite from the cath lab to work in the ITU. So it was a big challenge is to so ITU is some kind of a specialized system where everybody has to be trained to run the system smoothly. But then the staff is coming from the endoscopy suite to help us in there. So it was a big problem at that time to start with, but gradually, means it was thank goodness that everybody has worked very nicely, and people who has came from different specialties has helped a lot. Even in the ward, the neurologist and endocrinologist were seeing the patient of COVID. So ideally, they would have seen by a respiratory physician always, but it was difficult to get that many respiratory physician. So endocrinologists and actually neurologists were seeing the patient. Surgeons were following the COVID patient in the ward, and ultimately they were quite dependent on us to make decision about their admissions to the ITU, and then further management protocols, because DHA was issuing the management protocol every week like that, and they were changing protocols a lot. So we were like a node between the different specialty of the hospital to convey their message, what treatment we are changing now. So these were the major managerial problem in at that time. Major problem which we had faced for the patient communication on ethical issues were like uh, it was a quite strict lockdown in Dubai. Nobody was allowed to visit the hospital except somebody is dying. Initially, it was also not allowed. So even somebody is dying, just inform them the patient has died, and then the hospital will arrange some time to show to the relative when they can just see the dead body. And it was really traumatic, and sometimes breaking bad news was really bad. That means how will you explain the patient's relative that your patient has died when they have never met?
Indeed.
Maybe the patient is with you for 20 days, and they are not knowing even how they have died. So that was really difficult to explain that your patient is dying. And actually, UAE and Gulf countries are quite demanding in terms of communication, because they usually have a big families, and they have a different cultural structure. Maybe it's quite related with Indian subcontinent, but if you will compare from the Western country, it's different, because from one family you might need visit of maybe 5-6 patients, and now you are not allowing a single patient to come and visit the patient. So this was a big problem to deal with in terms of communication at that time. Another problem which has created in the middle, that many of our staff has got infection. Few of our emergency physicians has got infection, COVID infection. Our nurses has got COVID infection. So that has actually further aggravated our problem of manpower, because many of our expert nurses who were actually leading the team in ICU has got COVID infection, and they had to get self-isolated and treated. And one of the nurses has got admitted to our hospital and remained for admitted for 2 weeks, and this was really a problem. One of the ED physician was admitted to our hospital, and he has got treatment for almost 10 days with us. So these were quite difficult problem at that time. Yeah, definitely. So after finishing first wave, I have moved to UK. So I'm still in touch with my colleagues there, and they are still facing same kind of problems. But now actually the system has stabilized. They have got few streamlining in the system, so they are still better, but still in problem.
Thank you, Dr. Muzaffar, and it was really good to hear that. And again, to underline what Dr. Danish had mentioned, these barriers that we had built up between specialities, this little bit of maybe, shall I say, egoistical situations that we made of, moving patients between wards and all that. I'm glad these are some of the positives, if we may, that have come out of this pandemic. And in some way, it has taken us through this very difficult time. We had people of all specialities literally coming forward to work in the ICUs, to work round the clock in the COVID ward. So that is something we should not forget in a hurry, even though, like you said, the times are better. So that's something. So thank you for sharing that. We'll move on to Dr. Ellis Horn. Are you there? Dr. Ellis, if you can switch on your camera, please. He was having a problem with his data, I believe. Okay, we'll come back to him. We'll move back to India. Dr. Ranajit Chatterjee, thank you, sir, for waiting very patiently for us. Good to have you. Thank you for taking out the time. Most of the problems, I think, Dr. Kapoor has already covered. Was there anything different in your experience as to how you faced the pandemic and those really bad days?
Thank you, Dr. Derek D'Souza, giving me this opportunity to interact with you. I think you are from that city which has suffered one of the worst hit pandemics in India, that is Pune. And thank you, Dr. Russell and Dr. Arun, to give me this opportunity to share my experience. You know, I find that the whole world is singing the same tune. Whether it is UK, USA, developed world, or the developing world, this mega tsunami of COVID couldn't have been controlled by any system, whichever there is in place. So there was shortage of oxygen supply. The demand far overreached the supply. Yes, it was there with us. There was definitely shortage of ventilators, or pipette machines, but I will say in Delhi, at least overall India, the way the government acted swiftly after the initial hiccups was exemplary. The problem was, who is going to run these machines? How to give oxygen properly? How to run a biped machine? How to put a patient on ventilator? How to set the ventilator? How to prone a patient? And how to communicate with the relatives? These things cannot be done in a single day by a person who is not working in an ICU. I have been working in an ICU for the last 17.5 years. We are still learning. Do we expect a person from a different specialty like dermatology or ophthalmology to come and in a single day learn all the intricacies of intensive care? We are a country of 1.4 billion people. We have only 20,000 registered anesthetists, hardly 10,000 intensivists, and 1.2 million doctors. So 1:1,000 is the ratio, and this ratio is mainly, there is a big divide, urban-rural divide. There is heterogeneity in the healthcare system, and there is also heterogeneity in the population. We are a country with different cultures, religions, ethnicities, economic divide, educational divide. So if we compile everything, it is very easy to make certain algorithms, but very difficult to implement it. I start with the for example of my personal experience. What I saw in my own work, I got infected by COVID twice in both the pandemics. In the first wave also, in the second wave. First wave, it was slowly going into the, we didn't understand that this is going to happen in the second wave. When the Delta variant came and I got infected, being an ICU in charge, I was taking oxygen at home and I had to take CPAP machine at home. And I saw the scare of death in my wife's, in my children's face. They were scared. And this scariness was everywhere. Not a single family was not affected. And when I was taking this oxygen and one of my patients was admitted in the ICU, my sister's husband, he was hardly my age, just entering the 50s. And when I started counseling her, she only cried. I couldn't counsel. She went on crying, and ultimately I also went on crying. So that emotion was so overwhelming. You see, one of your staff is intubated and his friend is treating him. What will happen to that staff nurse, to that doctor? What he is going to face? He is also a human being. He is wearing a PPE kit. He is drenching himself or herself. And eventually he is getting infected. And he is getting scared whether I'll get bed in my own ICU or not. So this scariness was overwhelming, and you'll only understand it when you face it yourself. And I tell you, my ICU was dealing with one of the very few ICUs in Delhi who was dealing with non-COVID patients. We in India, we boast for the maximum number of deliveries in this country every day. Where these patients are going to go? Many of these patients are landing up with preeclampsia, eclampsia, and DIC in my ICU. And I got infected while putting a BiPAP in one of those patients who ultimately became positive. So there was a mixing, as Dr. Kapoor said. All time there was a mixing of patients, and we couldn't segregate. It's not possible. Humanly, it is not possible, because the test will come after one day. The patient is serious. What you are going to do? What about the MI patients? What about the patients of acute pancreatitis? What about the patients who have suffered some injuries and needs of immediate surgery? Completely forget about this. And after this, I tell you, so there is a stream of patients coming every minute, because intubation, many of them needed intubation. And after that, what to do? Where are the ventilators? Who is going to put the patient on ventilators? Who is going to set them? So a lot of training program is still needed in India. And the scariest part of this is that, what about our children? The future of the society. We have not yet vaccinated them. We are thinking of opening the schools. And on one hand, we are telling that let us not gather together in a crowded place. Let us segregate ourselves, let us sit at home. And on the other hand, we are telling, let us open the schools for those who are not vaccinated. What is going to happen? We are now more or less self-sufficient with the adult ICUs. What about the pediatric ICUs? As one of the doctors was telling, who is going to handle these pediatric patients? Pediatric patients are very difficult to handle, very difficult. So till now, we have a lot of homework to do. And my experience was really scary. I saw many of my friends dying. I saw many of them surviving. We helped in surviving many non-COVID patients. We helped in intubating and ventilating many post-COVID patients. Mucormycosis became a real scare in India. Slowly it has come down by God's grace. And I think in the next series of webinars, if you invite us, we can also share our experience. And I pray to God, really, let the third wave do not come here. And let it not infect our children. Because what I have faced in my life, and I've seen in my friends' life, let others do not face. Thank you.
Thank you. Thank you, sir. Very, very wonderfully said, and especially here in Pune, during the second wave. First wave, of course, it almost seemed like you were watching or listening to a horror story. But in the second wave, it became very, very personal. As you said, friends, families, in every society, it was, earlier they would talk about isolating a society, but when every society and every building, every flat had at least one patient or someone who was infected, it was very, very sad. And then true solidarity came in. And to some extent, people got over that initial fear, or maybe, and almost it became an untouchable if you heard somebody was COVID positive. But then people realized, no, we have to accept them because it came into every family, it came into every relative. And I echo your words that hope we don't go through this again and we learn. Dr. Ellis Horn, good to have you back. So I know you're having problems, but you are from the pediatric intensive care speciality. And of course, you would have had to do extra duties during this pandemic because Hong Kong was equally hit. How has it been for you, sir, and what have been your experiences?
Okay. In a sense, it's fortunate that children are not that affected. Altogether, for the last 1.5 years, we have about 1,200 confirmed cases of COVID. And of those, about 10.5% are children. So about 100, a bit more than 100 people are children. But in a sense, fortunately, there are no severe cases on children. Most of them are asymptomatic cases, and they spread around the germ to elderly people and other people, but they themselves are not that affected. And in terms of intensive care cases, there have been only 2 cases, and both of them are imported cases. So in a sense, children are less hard hit here in Hong Kong. Even for the 2 intensive care cases, they recover quite fast too. So this is something I suppose good, but it affects us in many other aspects. When children are admitted to the children's hospital, we screen them like crazy and sort of quarantine them. So their parents and their loved ones cannot visit them. And even in terminal cases, we deal with a lot of cardiac surgery and oncology cases. And many of these parents really demand more time to be spent on the children. But each day we can only give them 30 minutes or so. Now we have relaxed on the visiting time a bit, but it caused a lot of difficulty and turmoil to the family too. But interestingly, on screening for pathogens other than COVID, I mean, most of them, indeed all of them are negative. We screened and found many other organisms, viral and bacterial organisms that are much more severe in causing problems and disease in these children. So COVID really doesn't affect children that much in Hong Kong. Indeed, looking back, we found we have admitted 2 other children, not because of COVID, but more because of the vaccine that caused myocarditis and pericarditis. So this is another thing about COVID. And looking back in the some 16, 17 years ago, we looked after the first 10 patients with SARS. And in that time, children are a lot more affected. But fortunately, at that time, we didn't have any mortality in Hong Kong in children. And indeed, I saw the first 10 children with SARS, and we published our first paper in the Lancet about pediatric SARS. But this time, indeed, in 2020, when COVID first started, indeed, we predicted that this is a real SARS episode recurring. but people didn't believe. But we did write some papers up to warn people that this is SARS. And indeed, as you know, the virus itself is SARS coronavirus 2. So this is a form of SARS. Although not causing any mortality in children in Hong Kong, there are really a lot of psychosocial issues affecting children, a lot of psychological problems, and with social distancing, they are not allowed to go to school, and many other problems that affect them, and also affecting their parents. So now we are gingerly starting to reopen the schools, and another major issue is whether we should vaccine all these children in this time of the year. So in a sense, fortunately, we don't have that many in terms of mortality. However, there are many other things that are affected in Hong Kong. I think even in the adult population too. So thank you for allowing me here to share our situation in Hong Kong.
Thank you, Dr. Ellis, for giving us that short overview. And in fact, it's my pleasure to inform all our panelists and all those in attendance that we are looking ahead at possibly having a special discussion on the various issues facing the pediatric patients. And I'm sure at that point of time, we'll be discussing that in detail, as well as an update on the vaccine. So possibly we'll be looking at the variants as well as the need for vaccination in children. So we look forward to having you all back then, maybe in the next month or so. We'll send you the dates. I believe Dr. Arun Mehra has a question for you, sir. So if you can unmute yourself and you can direct the question to Dr. Ellis and maybe to the others. Dr. Arun Mehra, please.
Yes, Dr. Ellis, I have typed the question here. What were the special, we all know that in the case of children, there are always communication issues, and as you said, they are isolated from the family, so emotional problems. It must have all got enhanced also at the time of this COVID. So is there any special experience in that concern that you would like to share, sir?
Indeed, I think the major thing is that having been so used to spending the school time on air, it's very difficult to get them back to the school and observing the social distancing routines in the schools. So I think, and people are so scared, the teachers too are so scared of how to avoid infection and outbreaks in the schools. And another thing is the parents. During this period, really, many parents have to stay home to look after these children. This affects many of the parents' work. So, but fortunately now, I think people are starting to go back to school. This becomes a headache on the school teachers. There are other psychosocial issues that affect people. The behavior are different. The students are different now. So I've written some papers on some of these psychosocial issues that affect not just the children, it's affecting their parents and the school teachers too. I don't even know how far-reaching all these problems are in the society. But I think there are some prospective studies looking into all these that are potentially problematic in the next few years to come, because this period of COVID is so prolonged. It's nearly 2 years. And I'm sure that there are a lot of psychosocial problems affecting the upgrowing of these children in the few years to come next.
Ellis, we'd love to have you share the papers you have written. If you can provide us the links in the chat box, that would be excellent, sir.
Okay. I have to go back to look it up first, but I would send them all to our email connection.
Yes, you can send it to any one of us, and we'll forward it to everyone.
Anyhow, I was going to ask you also about the program for the pediatric, but you were looking after the intensive care unit or in the children's hospital. How
yes.
Did you have many children in what of the patients that you're having? What percentage would have been children that were going into the intensive care?
Okay.
Yes.
Now there are, all in all, there are only 10% of the affected people that are below 18 years, and so about 120 of them so far in the last 1.5 years. But these children are not sick enough to go to the. So they go to the PICU of regional centers, and there are only 2 that are sick enough to be in a PICU. One is a case of Kawasaki-like disease affecting the heart, and also they call the word COVID skin syndrome. Many syndromes are associated with COVID. So COVID skin, COVID heart, COVID this and COVID that, but most of them are just a form of SIRS, systemic inflammatory response syndrome, no different from this at all. So that one recovered quite fast, but that's not a local case. That's a case of a child who is from Russia. And another case is also an imported case, but not too bad, not too severe. And indeed, we saw another very interesting case of COVID-associated testicular inflammation, indeed, bad enough for orchidectomy to be performed. So one testis was damaged and removed in that case. But again, not serious enough to have to go to the ICU.
Very good. Thank you very much for that, Professor Ellis.
Dr. Purnima Basu, you had your hand raised. Do you have a question or a comment? Please, you can unmute yourself.
Yeah, thank you, sir. This is Purnima Barua from Assam, in the northeastern part of India. All right, so thank you.
Could you tell us your specialty, ma'am, if you don't mind?
Yes, I'm a microbiologist and I'm also the medical superintendent of Jorhat Medical College.
Wonderful. Welcome. Please go ahead.
Yes, sir. So we have been through this, the similar kind of, situation which has been mentioned by all the speakers. Experience has been immense. I mean, very similar. So what I would like to know is how easy or difficult was it for all those who have been, through this caregiving process during the COVID pandemic time to allocate or to assign the ICU beds in the time of scarcity, when there were a huge number of patients in the wards and they needed to be triaged, over there to be sent to ICU. So how did they manage? And what were the criteria that they had to keep in mind? Because for me, that was a time when I saw that all the principles of ethics were going somewhere. We were not being able to quite manage, So I would just like to know what are their experience in this particular matter of triaging patients from the inpatient wards to the ICU and allocating when there was so much scarcity of ICU beds. Thank you, sir.
Thank you, ma'am, for that. I think everyone had that as the top of their mind. Dr. Mukul, would you like to share your experiences and then we'll move to the others?
It was, Dr. D'Souza, let me tell you, it was a question which has really frightened me. I don't know how to answer it, actually. It was the most difficult thing that could have happened, And I remember the crisis which used to be there, the moment you used to get a demand for an ICU bed, I would phone up the administration, try to get a bed. And by the time we were able to arrange a bed for a critical patient in the ward, it would be almost 2 days at times. It was almost impossible. And all we could do is supplement something in the wards, maybe start high flow nasal oxygenation or something there. but it wasn't easy. And I know when I was myself down with COVID at home, I used to receive calls all the time. Can you help us get an ICU bed? And it was I was absolutely helpless. I know ethically it was, and morally also probably it was wrong on my part to say no to them. But at times I had to say no to them. I can't help it. And then I used to tell, used to suggest, my hospital is one of the bigger hospitals of Delhi. I used to suggest to them, why don't you look for ICU beds in the smaller nursing homes? They have also developed ICUs. I used to advise them to go there. And I used to feel very small and very, I used to feel awful about it all. Telling people to not to come to my hospital, which has a better setup, but to go to a place which could offer them an ICU bed. That was the state. And I'm really telling you, it was really awful.
Can I ask, thank you very much for that. I was going to ask Dr. Danish, do you have a criteria that you, Dr. Danish, did you have a criteria so that you used when you had to make the step of allocation? We are talking about someone from the ward, but you've got a limited number, and you had to make a decision. I know that's not what you were trained or what you were used to, but in a situation like this, as Dr. Purnima was talking about ethics, I know there were various protocols for triaging. It might not have been, following all the ethical, but where did you all have some form of a protocol that you, or if not a protocol, even an unofficial or whatever, your own methodology of how you're going to make a decision, an impossible decision, but you had to make that. Was there anything like that you followed?
Yes, Professor. Ageism was being practiced, unfortunately. Anyone who was over 80, even though without comorbidities, it was very, very unlikely that they would get a bed in ICU. So younger patients who are younger and as well as fitter patients would definitely get a priority. But what also helped us to create capacity all the time was the system in UK where you can withdraw treatment. And if you thought patients were not benefiting from maximum medical treatment for a particular period of time, then it was time to palliate them. And that was what was helping us rotate the beds and create more space at the time. But despite all those measures, the bed pressure was always the biggest issue. And there were no, yes, we would try and practice the best, most ethical way of doing it and follow the protocols, as in see what the patient's merits were by getting an ITU bed, and based on that decide if it's suitable. Otherwise, we had palliation wards available, and it wasn't that treatment was not being given, but yes, people were kept on BiPAP or CPAP, but complete ward-based care was delivered to them. And there was a ceiling of treatment that they will not be suitable for any level 3 kind of intervention. That was probably how we were trying to minimize
the reason I asked you that was, in United Kingdom, you have, similar to Australia, which is a universal health, which is every citizen is entitled to that care. I can see in some other parts, like Dr. Mukul, your hospital being a private is maybe slightly different from what you would face in the NHS, or for that matter in Australia, where we, everyone's it's universal health, and there's a Medicare agreement that every citizen is expected to get care. So it makes it a little different. And I wonder what Dr. Leonardo from Carvalho from Brazil, how did you, what methodology did you follow in Brazil when you had this difficult situation of having to decide who gets that intensive care bed?
Well, there are different protocols that may be followed by different institutions. Here, our Intensive Care Society, Brazilian Intensive Care Society, published instructions about triage, and we don't use the only the age to decide whether or not the elder will get an ICU bed, but if they are fitted, how many comorbidities and SOFA score and other measures. At the peak of the pandemic, it was difficult to decide because you know that if the person didn't get a bed, they will mostly die. So we have to decide whether to palliate one of other patients. But it was very difficult to understand how to triage and have good quality of care to all patients.
Very good. You're giving us a different, I mean, the different ways. The problem was the same everywhere. And I guess that was, I wonder if Dr. Liz could tell us how they did it in what was happening in Kenya in terms of having to allocate or to make the decision.
Thank you for that, Dr. D'Souza. So here in Kenya, we didn't really look at ageism or high likelihood of recovery. Here, any patient that needed ICU care was eligible to be admitted in the ICU. However, due to the lack of beds, one of the strategies we used is our HDU was converted into sort of an ICU system. We also converted other units that had the capability of isolating patients, such as the coronary cardiac unit, the cardiothoracic ICU. We did convert them into COVID ICUs when necessary. Another tactic we employed is extension of critical care personnel into other isolation wards, just to, since we are already extending ventilators and high flow nasal cannulas and also non-invasive ventilation methods into other isolation wards that are not in the critical care unit, we found it important for us to extend our services into the medical wards where these COVID patients were admitted, and assist the medical doctors on the ground on how to manage patients who are ventilated and have high oxygen requirements. Unlike the UK, as Dr. Danish has said, here in Kenya, we do not have any palliation wards. I feel like that's a step closer to litigation here. So any patient that, no matter the age, no matter the severity or the poor prognosis, any patient was eligible to, get a bed in the ICU. And these discussions were held by as I said in the comments, they were held by the interdepartmental units, and everyone was involved in deciding which patient stayed in the wards and got the ventilator in the wards, and which patient came to ICU and got the vent in the ICU. Thank you.
Thank you very much. Yeah, well, very interesting to have a perspective from different parts of the world. That's. Thank you all very much.
Dr. you raised your hand.
Actually, I wanted to ask regarding, as Dr. Danish raised the issue about palliation. So I wanted to ask our friends from different countries, what were the policies in their countries? Dr. Liz has already answered that, but that becomes the next question. I can see that Dr. Muzaffar and Dr. Danish and Dr. Mukul all have their hands raised. So if they want to really address this first question, they can do so, and then we'll go on to the question which I have asked.
Yes, Dr. Muzaffar, you can.
Yeah, thank you for calling me in. So I can give a good comparison between the two systems. So initially, when on the first wave, I was working in Dubai. In the second and third wave, you can say I am working at present in UK. So yeah, there is no DNR policy. There is no policy to palliate in most of the Gulf countries. There is no, but it's similar to almost India. Like earlier I worked in India, there is no DNR policy in India also in place. So it become really difficult to, like, knowing the patient that is not going to survive. The lung CT is showing that it's totally fibrosed, but you have to continue the treating as a full case, means everything to have to be done until the patient dies. And despite of knowing the prognosis, you have to do CPR, which is altogether in contrast to the countries where we have a full DNR policy, we have a palliation policy. So when I reached to UK, I found it's, I mean, I have always read in the book, but I have never did in personal life, that we are deciding the patient on the basis of prognosis of the patient. So because in UK we have very limited ITU bed in comparison to number of beds in the ICU. So my hospital in UK is 700 bed and having 10 bedded ICU. In comparison to in Dubai, I was working, has got 100 bedded hospital having 10 bedded ICU. So this is the ratio. So seven times less number of ITU beds in the UK in comparison, if you take in the ratio of the hospital beds. So if I will try to answer the first question about the Dubai, admission was quite straightforward because DHA has taken whole authority of admission and discharge of the patient. But so they kept the patient in, even in the hotels, in some makeshift hospital, and when they getting deteriorated, they used to come to our hospital. So we have faced sometimes the problem of beds in Dubai, but not always, because they used to manage somewhere and they used to prepare a number of beds beforehand. So like they used to order, okay, so we are expecting that our number of patient will go up because we have a lots of non-serious patient in our hotels and makeshift hospitals. So now you have to increase your number of beds from 10 to 20. Then they ordered, okay, now you have to increase the number of beds from 10 to 20 to 30. But still, sometimes we have to keep patient ventilated in our emergency, like 2 or 3 patients used to be in emergency waiting bed to be vacated inside the ICU. Some patient used to be still remaining in the on CPAP in the ward. But we have managed somehow there in Dubai. When I reached in UK, this was really difficult because number of patients are still in UK. We are struggling when providing the number of beds. And but good thing is that we have a palliation system available. We have a DNR policy available, and at least we can discuss with the patient. And good thing is that acceptance to the society is there. So means everybody who is coming to the hospital, they accept DNR. But in comparison to, if you will compare to our culture or Gulf culture, you will say patient don't accept DNR. They don't accept, do not escalate treatment. So yeah, there is a bit different if you will compare from the Gulf and the UK system.
Thank you, Dr. Muzaffar, for bringing that out. And I suppose that's where the cultural sensitivity comes to the fore and helps us to understand and communicate better. And it's good that you brought in the comparison for us. Dr. Danish, would you like to take that forward?
I think I'll just add on to what Dr. Muzaffar has just said. I mean, as you mentioned, there's a framework in place to implement palliation or to implement these policies. Staff is trained. Staff has got perfect awareness when to initiate these kind of communications to the family, and the family is as well very accepting of it. A lot of patients have advanced directives in place whereby they do not want to be intubated or resuscitated. So that makes it a lot more easier. In COVID times, the nursing home, that is the elderly patients who were in the care homes, they were never brought to the hospitals, and those patients were not sort of counted in the hospital deaths. So that gives you a perspective that these deaths the hospital deaths were generally, most of them were slightly younger, and patients with a social network being intact who actually came to the hospital. So it was quite clear the old and frail were never facing those dilemmas of escalating. However, I'll just add on to the point that Professor D'Souza raised earlier about protocols and how to admit. As I mentioned in my talk about the critical care networks and transferring patients from one hospital to the other. So traditionally, critical care networks have been available in UK. So a group of, let's say, 5 or 6 hospitals form a network, and if there's a huge demand of beds of ICU beds, then other patients get transferred to the other, and it just mitigates the crisis. However, in COVID, it was all over the place. I mean, the whole region was overwhelmed. So that's why patients were being transported from London all the way, 5 hours up north. And this definitely gave a breather to the system, where we knew that the surge is going to follow us. But those days where other city was overwhelmed, we were able to support them, and this did bring down the pressure on the healthcare personnel in taking those critical decisions.
Well, I think in Australia too, we never reached that stage because there was enough capacity and there weren't enough cases, but they did have that ability to network or to transfer, even within, even not necessarily out of the city, even within the metropolitan network from the various networks. Yes, they still have that protocol ready to, both in New South Wales and here, to use the network in transferring to manage the load, or these surge, what they call the surge capacity. Yeah.
Dr. Mukul, please.
Thank you once again. I wanted to add one thing. It was not that we did not extend our capacity. We extended our capacity. We have got multiple specialty ICUs in our hospital: respiratory ICUs, medical ICUs, surgical, onco surgery ICUs, everything. Everything was occupied. During the surge in the second wave, everything was occupied. And despite that, all HDUs were converted. But despite that, we didn't have any beds in the ICU. And if I used to phone up for a nice ICU bed for somebody, I would get an answer: you'll have to wait for a patient to die. An unfortunate answer that you'll have to wait for a patient to die, only then you'll be able to get a bed. I know lots of people. I know personally, who moved all the way from Delhi in an ambulance, which was well equipped, to Agra to get a bed in Agra. Some patients moved from Delhi to Himachal Pradesh, Chandigarh, to get a bed in the ICU because they found out on phone their beds available in there. It was a crazy situation, and ethically, of course, not right, but whatever was there, it was a crazy situation. No ethics could be followed at that time. Thank you.
Very well said. I personally know where I would get calls from people, and I know patients who moved from Delhi to Chandigarh. A couple of them did survive despite all that. And really, it was a harrowing time for all of us, and there was no question of even thinking of ethics or anything. We had Professor Ashok Saxena as well here. Sir was esteemed speaker at our last session where we had it 2 weeks back. And he has expressed in the chat box part of the experience is literally being threatened. What has been your experience in this front, and you would like to contribute something? Yeah, you're muted, sir. If you can just unmute yourself, please. Yes.
Am I audible?
Yes.
Yeah. Well, very good evening. Of course, good morning on the other side.
Yeah.
it was a terrible experience because as everyone has mentioned, that all hospitals, especially in Delhi, were falling short of ICU beds, and this thing, one of the episode where I mentioned in chat box, that was at midnight, and I mean, like people used to look at the the inside of the ICU through someone taking the help of their networking, that who is the patient who has been declared and dead, and then obviously the wrapping up of the body takes some time, because the mortuary was already full, so it used to take anywhere from 2 to 4 hours for the body to be taken out of that particular ICU bed onto the mortuary, and they will just be looking for the opportunity that yes, they will throw their patient onto that bed without even taking permission of the sister in charge or the doctor on duty or the consultant or anyone else. So it reached to that stage in one of the night duties that the president of the nurses union, and well, because as they always look after the welfare of their own community and ignoring the severity of the actual COVID-19 patient who is in need of ventilator support, and one of the nurse was actually just a mild to moderate, I can say, category of COVID-19, and they said, if you don't admit our nurse patient, we will see what we can do to you, and those kind of settings were there, and so that is one aspect. And the second aspect is that in addition to this kind of episodes happening, there were thefts also, because one of the although the government of Delhi had provided tablets to each particular patient in the COVID ICU, but in addition to that, people were carrying their mobile also, and one of them had the patient had purchased this particular mobile just 2-3 days back, in one of the very expensive type of that particular model, and there was a theft, and then the family was after us, that I mean, how can it happen, and those kind of things, because everyone is in PPE kit, and it becomes very difficult. How can you label anyone as a thief till you of course, because CCTV coverage was there, but not at every point. So that was another aspect, and the other one was I don't think whether you have heard about it, but at GTB hospital, we reached a stage. This is in the eastern part of Delhi, where the entry gate of the hospital had to be shut down. I mean, you can't even imagine that the main entry gate of the hospital had to be shut down because all the ICUs were full, all the wards were full. We had reached, almost to admission of 950, approximately, and all the corridors were full. All the, the main casualty area were full, and there was, kind of chaos happening over there, and those kind of things. So the hospital gates remained shut down for almost 3 days, with the permission granted from the Honorable Health Minister. So because there was no other option left, there was no other option left. And it was, I can tell you that one of the good thing also which happened was that the government of Delhi then planned for, installing hangar, that particular 500 bedded ICU hangar. And this is a very special and unique thing which happened at 4 or 5 locations all over India. One which happened, there were 3 in Delhi, one near the airport, one was actually just opposite our, there was an open ground, so opposite our GTB hospital, a 500 bedded ICU facility was opened on 12th of May. But by that time, of course, many patients had, the wave had toned down. So we had, in addition to our GTB hospital, we had almost admissions of 250 in this 500 bedded ICU in the hangar area, which was absolutely air conditioned. All 500 beds had ventilators, BiPAP, and HFNO, and all 500 beds had multi-para monitors. So that was a very unique thing, which I must say happened with the help of donations coming from abroad, and also with the help provided by government of Delhi. So these are the 2-3 things I thought I must mention it over here. Thank you so much. Thanks for the opportunity.
Dr. Saxena, sir, this highlights what we have always been emphasizing and what Dr. Russell always emphasizes and Dr. Derek always emphasizes, the issue of solidarity. That is what will get us through difficult times.
Exactly.
Emphasized in all our discussions, solidarity. I think that is a wonderful example of solidarity which you have mentioned, sir.
Thank you so much. Thank you.
Thank you, everyone. It has indeed been a wonderful discussion. Thank you, each of our speakers, each of our panelists. You'll have really gone into the nitty-gritties of what you're faced, and including giving us a view as to how we can take some preventive measures. So thank you for that. I now invite Dr. Russell D'Souza to please summarize and close the discussion for us.
Thank you very much, Professor Derek D'Souza. Thank you. Look, I think it's been an excellent discussion here. We brought again, as Arun, Professor Dr. Arun said, solidarity. We see from different parts of the world here coming together, all dealing with the same issue, and we're all, as we said, we're all in this pandemic together, and hopefully we'll all come out of it together. But what's important is humanity on every part of this globe that facing this, and how this today we are talking about the discipline or the of critical care and intensive care, having to cope, trying to face the challenges, not only of clinical challenges, but indeed the ethical, the moral, the human values. Many of us described what it was, what they knew, that how can I tell what am I to say, there's no bed, or you have to say the word, you have to wait for someone to die. And this indeed is very important, and brings us all for a moment to reflect on what it is that the profession, the professionals, the healthcare professionals, have been contributing to this in this pandemic, to bring solace and bring comfort and bring life, or to hope to so many people around the world. And I think this today's presentations set by three distinguished speakers set that scene. And then we had this wonderful discussion. I think we probably, all of us, knew what it was. I'm talking from Australia. We didn't really have as you, and we were aware of what happened in Delhi, in India, that certainly in United Kingdom, certainly in Brazil. I know Hong Kong they did have problems, but they have solved most of their problems to some extent. And here in Australia, we avoided, we managed it, but we are lagging now because of that initial period where we didn't have too many cases. They controlled it well. That led to some amount of we became complacent, and so the immunization fell back, and so we are now trying to catch up with that. But of course, this issue of having to ration, as it were, not just beds but the ventilators, and the result of this, I'm a professor of psychological medicine, and part of it is organizational psychological medicine. We have begun to see for moral injury, something that we only saw previously from returning from the battle. So we see now medical and nursing and other healthcare staff having to deal with moral injury, the effects of moral injury. And this is what you'll have described is your place where, or the direction in which, or the situation in which one is placed, having to make these decisions leading to moral distress and moral injury. So thank you all very much for that.
Dr. Russell, we have Dr. Deborah
Cavalcanti,
who's the Vice President from Brazil of the Regional Medical
No,
Council.
I know that. I was going to. Deborah is not just there; she's part of the program, a part of our program, not with our chair, and certainly with the Department of Education. And now she's also with the Art and Bioethics of Mary's unit. So, Deborah, thank you. And I think Dr. Deborah is with Lincoln, Lincoln, and he had to leave. He sent me a message and he said, Deborah is going to be there. So that's very good.
Would you like to, I think she raised her hand, Dr. Russell. So, Dr. Deborah, over to you.
Yes, I want to thank all of you because you are heroes in all the countries, working for the people and being transparent and with big solidarity with the people. It's very important for us as a doctor to stay in the place of the patients. In the name of Dr. Lincoln, I congratulate all of you, in my name too. It's a big honor for me. Every meeting I say, I'm very happy to be part of this team. It's an excellent team. And I want to invite all you to be here every meeting, every webinars. Every webinars, we learn many things. I'm not specialist in intensive care. I'm a breast surgeon, but I'm a professor and I study bioethics a lot. I try to be a good bioethicist. And I want to invite all of you, and I want to congratulate especially Dr. Leonardo Carvalho from my country. Thank you very much for your great presentations. Have a good week. Have a good week, and God bless all you.
Thank you. Thank you, Deborah.
Thank you, everyone. And
I did start with solidarity. That was what we started with, Article 13, and we end again with that concept of solidarity and cooperation. Yes, you want to say something?
I just wanted to thank everyone who also contributed in the chat box to the discussion that was going on there, especially Dr. Vivek Sharma. I think that was a very poetic depiction, and I encourage all of you before this meeting ends to go back and just go through the chat box. It's very interesting, and especially how everyone has contributed there as well. So just wanted to place on record all the thanks for that as well. Hope to see you in the future editions. We'll be sending you the information. Thank you all for being
every
here.
fortnight. We have every fortnight, so it'll be in 2 weeks from now.
Thank you.
Okay,
everyone,
thank you.
And good evening, good night, good day, wherever you are.
Stay safe and stay well. Thank you and bye-bye.
Thank you.
Thank you, Derek.
Not at all. Welcome.
Oh, Mary, thank you. I should have got you to say. I didn't see you.
No. I had an emergency. Mom was not too good.
Thank you, everyone, for being here.
Dr.
See you
Mary,
all.
I'm waiting your orders.
Sorry. Welcome.
You are my boss.
Welcome to my team, Deborah. Welcome.
Okay. Thank you.
Thank you, everybody.
Thank you.
Have a good week.
Same here. Have a good week, everyone. See you, Dr. Russell. We'll have a chat in the morning.
Yeah, tomorrow. Yeah,
we'll catch up. Thank you, Dr. Arun Mehra.
Where is Arun? He's gone.
He went up.
Okay, Derek. So tomorrow we'll try to finish that up.
Yeah, we'll do that.
Yeah. Peter Prashant was there. I wanted to say.
Peter was there.
Yeah.
Peter was there. Rizwan Taj also was there, but then when I wanted to call him, he had gone offline.
Yeah, Rizwan, I saw Rizwan. Mohandas was there too.
Yeah, Mohandas also came. Dr. Mitra, are you there? Thank you. Good to see you. I hope all is well.
Yeah, presenter sent me a note. He's going to be.
Thank you, everyone. Bye-bye.